So the next talk on complex biometry, we have our go-to guy. Any complex scenario, Jeyanthan can give evidence-based advice on it. He's a pediatric ophthalmologist and refractive surgeon. Over to you, Jeyanthan.
Thank you, Atik. Pleasant morning to everyone. Okay, whenever you have an issue with any of these pillars of your IOL power calculation, that makes your situation more special. We'll start with the keratometry. So to remember, if your Mayas are not crisp and clean, the validity of all your other measurements are going to be diminished. May it be a manual keratometer, automated keratometer, or an optical biometer. Let's see one example. This is a LensStar image. Instead of just going ahead with your blank values, always do check your image quality and the standard deviation. If the image quality is not good and your standard deviation is way ahead, always discard these values, treat the patient for ocular surface disorders, get them back for remeasurement, and then go ahead with your calculation. Next is the keratoconus. The keratometry in keratoconus is going to be inconsistent. When I mean inconsistent, it says different instrument is going to give you different values, and within a machine, you're going to have a less of repeatability. All this is because of the irregular astigmatism that is present. An unusual anterior chamber depth will lead to an erroneous ELP calculation that will lead to a wrong IOL power calculation. The visual axis is not on the apex but on the cone, and always remember the keratoconus creates a negative spherical aberration which is going to affect your IOL calculation. So once you have the keratometry values, it is always better to recheck with your tomography. The main advantage of tomography is that it will give the health of your posterior cornea, it will give the health of your anterior cornea right from the center to the periphery, and of course you can grade the keratoconus with the tomographers. Never use a SIMK value. Axial length preferable to be used from the optical biometers. So once you have the K and the axial length, for a mild to moderate keratoconus, it is better to use an SRK-T formula or a Barrett Universal 2 formula. For a severe keratoconus, definitely choice of IOL is going to be very difficult. It has to be based on case-by-case basis. Issue with axial length evaluation will start from the higher axial length. In eyes with an axial length more than 30 millimeters, a posterior pole cephaloma temporal to the fovea was quite common. The cause of error in these cases is mainly because of the irregular shape of the ocular wall. Remember, the deepest portion of the cephaloma may be located eccentric to the macula. When it comes to an ultrasound, if at all if it is a contact ultrasound, remember these eyes will have a low scleral rigidity and the chance of indentation is going to be very high. There will be an inability to display a distinct high retinal spike. And these ultrasounds will give only the anatomical axial length rather than the refractive axial length, resulting in IOL power that is going to be too low. So the solution is to use a vector A-B scan, do a B scan, locate the fovea, and then do an axial length measurement using the A scan. It can be used to demonstrate the shape of the posterior ocular wall and relationship of the macula to cephaloma as well. If at all, if it is an ultrasound, it has to be an immersion, and a probe with the fixation light is preferable in these patients. The best of it is to use an optical biometer, especially an IOL Master 700, which measures the axial length by directly visualizing the fovea on the OCT image during the measurement. So once you have the axial length measured, a cephaloma is like any of the high axial myopias. So coming to the formula, traditionally an SRKT is used. A fourth generation formula of Barrett 2 has the best predictive value in the myopic eyes and the lower IOL power. Let's see what we have in the literature. This article in 2019, when we had the last face-to-face conference in 2020, it was concluded that Hill RBF and Barrett were more precise than Haggis, Hoffer, Holiday, and the SRKT in myopia. But the Hill RBF was independent of the axial length. But recently, now in 2022, the JCRS article concludes saying that the best overall results were noted with the Barrett True Axial Length formula, EVO, Hoffer QST, K6, Olsen, and Pearl DGS formulas, closely followed by the Barrett. So Barrett once, which was thought to be the universal, is actually becoming followed by Barrett formula. Right. So coming to the extreme hyperopia, the issue is that you have an altered anatomy, and if you're going to use a mean sound velocity and an automatic biometry mode, either you won't get the values or it will be erroneous. These eyes will have a highly magnified error. For example, a single millimeter change of axial length from 20 to 19 will produce a 5 diopters of change in the IOL power. This small shift in ELP leads to a bigger surprise. The main reason is the lens is thicker and is very closer to the fovea. So if at all, if it is an ultrasound, it has to be an immersion to reduce the indentation. So in a semi-automatic mode, with the corneal double peak echo clearly discernible, all the other 4 ocular landmark echoes may be adjusted for the optimal steepness, thus achieving the best orientation. It's always better to use an optical biometer and use a formula that calculates ELP from multiple parameters. Ultrasound, go for an Hoffer cube. Optical, better to use a Barrett Universal 2. And if the ACD is less than 2.4 mm, use a Haigis formula. If you have an edema or a tumor sitting on the macula, it is going to affect the outcome of your calculation because it prevents the display of distant retinal spike and causes a shortened axial length. If the patient has got a dense cataract and you don't have an access to optical biometer, there are certain markers in which you can identify these. They are like unexplained spikes along the vitreous base, inability to display a distinct high retinal spike, abnormal separation of the retinal spike from the scleral spikes, an inconsistent axial measurement of more than 0.2 millimeter, an inter-eye variation of more than 0.3 millimeters. Astrohyalosis, vitreous hemorrhage, gas needs a high gain setting in ultrasound mode to obtain spikes of sufficient height. In silicon oil filled eyes, the source of error is mainly because of the low sound velocity, leading to an apparent noise attenuation and difficulty of identifying the retinal spike. Basically, silicon oil changes optics of eye due to its refractive index. So, an ultrasound travels slowly in the silicon oil. This has been perceived by the probe as a longer axial length, which gives a lower IOL power. Usage of a standard sound velocity can give an error of up to 8 millimeters. So the simple solution is to use a correction factor of 0.72, which will give a rough estimate of the power. The best is to use an optical biometer because the change in refractive index is less affected in case of an optical biometer. Denser cataracts, where the optical biometer doesn't work, use a maximum gain setting to obtain the spike of sufficient height, and you can use a semi-automatic mode. This situation will be complicated if the patient has got a poor fixation due to low vision, nystagmus, blepharospasm, or strabismus, which could be handled by blocking the patient and then redoing the calculation. Piggyback IOLs depends whether it is a primary or secondary. If it's a primary, use a Haigis or a Hoffer formula, arrive at the IOL power, divide the power into two IOLs. A single piece IOL, single piece hydrophobic IOL goes into the bag with full power, and three-piece hydrophobic IOL goes into the sulcus with one power reduced. If it's a secondary IOL, it has to be only based on the refractive error. No knowledge of the primary implant or an axial length is required. Use a Holliday's refractive formula or a Barrett RX formula. The issues with calculation, the main situation here is a post-refractive eyes. The reason why we have inaccuracy is that we have a keratometric index error, radius, and the formula error. In keratometric index error, generally in calculation, you use a refractive index of 1.3375, which is actually a fictitious one because it assumes the anterior and posterior cornea to have a specific ratio. It works well in virgin eyes, but when it comes to a post-refractive eye, where the anterior cornea is actually altered, the ratio of anterior to posterior is also altered, so the ratio becomes invalid. So in case if you're going to use this in a myopic correction, it will overestimate the K, underestimate the IOL power, resulting in a postoperative hyperopia. Higher the attempted correction, higher will be the over or the under correction. So the solution is to use a technology that measures both the curvature, either using a sheen plug imaging or an OCT-based system. Next is the radius error, where an instrument extrapolates the central cornea from the paracentral measurements. Imagine the central cornea is already flattened and the paracentral cornea is going to be steeper, so the K will be overestimated. This is more relevant in eyes with smaller optical zones and decenter aberration, which was very common in the older generation machines. So use the central values from the tomographer rather than a SIMK value. Formula error, remember the keratometry is at fault. So when you're going to use the keratometry for the ELP calculation, all these formulas are going to be erroneous. So in a myopic ablation, it's going to end up in an undercorrection of the IOL. So the solution is to use a formula which doesn't use a K for its calculation, and any other parameters used for ELP could be used. One such formula is a Haigis, which is already incorporated in IOL master, or it's better to go for a double K method. Depending on the preoperative refraction and the keratometry, you can go for the preferred double K method. In case if the patient doesn't have a preoperative data, or if it is unreliable, which is going to be the most common cause in our cases, you can go for the older technique of Shamas and Maloney's method, which is there even in the older generation optical biometers. But the current concept is to use a Barrett True K or a Haigis L. And the look forward future is going to be a Gaussian optic formula and the corneal ray tracing phenomenon, which uses the Snell's law. This is a Barrett True K formula, which is incorporated in ACRS, APSRS online calculators, feed through use calculator. Whatever possible measurements you are able to take in your clinic, just input and get the values. It's a small case wherein, this post-refractive patient, actually we did a lens star calculation and an ARSS calculation. You can see that both the Shamas and the Barrett True K value was absolutely corresponding both for both the calculation. So to conclude, remember there is no one size fits all calculation method for all these cases. Understand the science of IOL calculation, keep validating your measurements once in a while, stay informed about the latest development, and most of it, don't remove yourself from the process. Don't let it go through an optometrist. Keep involved, especially when it comes to such a special situation. Thank you.
Thank you so much, Jeyanthan. I thank all our speakers, Aditreya, Arul sir, Ramesh sir, for this wonderful session. And thank you so much. Thanks AOI Scientific Committee and Partha sir for this amazing opportunity.